Hello, my name's Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director of GPnotebook Education. Welcome to the current season of GPnotebook Podcast, a bite-sized regular chat for all of us working in primary care. Podcast will cover clinical tips and hacks as well as hot topics to help make our lives a wee bit easier, but ultimately to help improve the lives of our patients in primary care. I've been recently involved in planning a series of webcasts for healthcare professionals in the UK, which are all taking place during May 2021 as part of what we're calling Chronic Conditions Month. The webcasts, which are being run in association with GPnotebook, are designed to help all of us working in primary care with the significant challenges we've faced in diagnosing and managing chronic conditions over the past year in the midst of the COVID pandemic. Healthcare professionals in UK can register to attend all the events for free at www.chronicconditions.co.uk. So I hope you'll be interested in joining us. And to accompany these webcasts, the Chronic Conditions faculty has recorded a series of podcasts in the past few weeks in which we provide some practical advice and suggestions to help you optimize care here and now across a range of conditions. So, without further delay, please enjoy the second in this series of special episodes. This one is brought to you by Dr. Peter Bagshaw and Dr. Yassir Javaid.
Okay, welcome everyone. Hello, I'm Peter Bagshaw, GP, CCG Mental Health Lead and author of An Older People's Mental Health, a practice primer. I'm delighted to be joined today by Yassir Javaid, GP with special interest in cardiology based in Northampton. Welcome to our new podcast, which comes to you as an introduction to Chronic Conditions Month 2021, to be held throughout May. This will include a whole string of interactive and informative webcasts designed to address the primary care challenges of diagnosing and managing chronic conditions at a time when COVID-19 has thrown out the rulebook. Today in this podcast, we're going to be discussing palpitations, when to worry, and the interplay with mental illness. So, Yassir, do you want to tell us a little bit about palpitations and give us an introduction?
Yes, of course, Peter. Well, firstly, thank you very much for that introduction. It's a pleasure to be here. So, look, palpitations are, for me, really bread and butter general practice. They're a very common presentation in primary care, one of the commonest reasons for referral to cardiology. And of course, they're associated with significant distress and anxiety for some patients. The good news is, though, most are thankfully benign. Significantly less than 50% would be due to an arrhythmia, but many of which actually have no prognostic significance. But there is a high incidence of related anxiety disorders, which of course can be a cause and effect of palpitations. So really the challenge from our perspective as frontline clinicians in general practice is to try and identify those patients who do have a significant heart abnormality or are at risk of a potentially bad outcome, but reassuring the others, which are going to be the majority. And the other good bit of news is this can all be achieved in primary care through careful history taking and some simple investigations. We don't even have to be very fancy with the investigations. And I guess that's what we're going to hopefully try and tease out and discuss during this podcast.
Well, that's really good to hear, Yassir. I have to say it's a source of anxiety for me. People will often come in with a very indistinct story of palpitations. Often it only happens rarely. And the question is, who do I send for a Holter monitor? Who don't I? What tests do I do? So, yeah, perhaps you can sort of dive straight into giving me some tips and hints.
Well, absolutely. I think for it's really important, actually, for most assessments in medicine, try and in the back of your mind as we're taking the history, and the history is absolutely crucial, just remember that potential differential diagnosis. You know, what are the main causes of palpitations? Yes, of course, arrhythmias are going to be one potential cause. We've always got to be wary of patients with underlying structural heart disease. So arrhythmias, I would classify those as electrical issues. structural heart disease like heart failure or someone with a previous heart attack. Then there's this big differential diagnosis of psychosomatic disorders. And just to make sure we're not missing it in our history and initial workup, just remember some of the systemic causes, and we must take a decent drug history. So if I just go through those very quickly, one by one, in terms of cardiac arrhythmias, the vast majority, if it is a cardiac arrhythmia that's causing the palpitation, are either going to be supraventricular or ventricular extrasystoles, in other words, ectopics. And that can be very easily teased out in the history, which we'll move on to maybe a bit later on. Obviously, there are going to be some patients that have genuine tachyarrhythmias, things like SVTs or atrial fibrillation, which is the most common sustained cardiac arrhythmia. In terms of structural heart disease precipitating palpitations, the main ones to worry about are patients with significant heart failure, a previous heart attack, any sort of congenital heart disease, or a history of cardiomyopathy. And then this is really your remit, isn't it, Peter? This is your expertise. Psychosomatic disorders, in particular patients with underlying anxiety, depression, and other somatization disorders. Give us a flavour, Peter, for how these conditions could potentially precipitate palpitations in terms of their sort of impact on the physiology of the cardiovascular system.
Absolutely, Yassir. And one of the great things about these podcasts is that because we're coming to the subject from different areas, we're able to explore the interactions between these different things. And that's one of the great things about chronic conditions. So, as you mentioned, psychosomatic, and in a way, I kind of almost throw it back and say, it's not psychosomatic, it is somatic. So people with anxiety have increased levels of adrenaline and noradrenaline, which we've always been taught are hormones, but they've actually now been found in the brain and are also classed as neurotransmitters as well as hormones. And then you've got corticotrophin-releasing hormone, CRH, and again, it's been shown that high levels of this are associated with anxiety, and that can turn on the HPA axis, the hypothalamic pituitary adrenocortical axis. So you've got this complex interplay where something that's designed short-term as a fight or flight, turn on the cardiac system, make us able to run away or fight to maximum efficiency. If that goes on for long periods of time, it has all these unwanted effects. And in a way, the feeling of anxiety is almost a side effect of having these hormones coursing through your system. There's another interesting couple of hormones that might be worth, or neurotransmitters that might be worth mentioning. So serotonin we often think of as being associated with depression and happiness, but there's an idea that low serotonin levels are also associated with anxiety, as are low GABA levels. So both of these also play a part. So that's a sort of a brief introduction, but I'll throw it back to you.
Well, that's really interesting, Peter, because as I said earlier, anxiety and somatic disorders, they can be cause and effect. So there could be actually an underlying arrhythmic cause for the palpitations, but if that fuels anxiety and you get increased catecholamine level, that's just going to potentially make the palpitations worse in terms of severity and frequency. So there is a very interesting interplay there. Absolutely. And I guess part of our job is to provide at appropriate times definitive, and I think the key word is definitive, sort of reassurance, if appropriate, to try and break that sort of anxiety drive that can be propagating the underlying issue. And I said also systemic causes. Always have in the back of your mind, could there be something systemic driving palpitations? And basically anything that is driving a faster and more vigorous heartbeat can do this. So, part of your workup should always be to rule out a high cardiac output state. So full blood count and thyroid function to rule out hypothyroidism and anemia. Patients who are pregnant, our female patients who are pregnant, obviously the much higher cardiac output state, and also patients who have an underlying sepsis or fever. That's going to, again, through various hormonal mechanisms, are going to make the heart beat more vigorously. And anything that provides stimulus to the heart to beat more vigorously and quicker can precipitate abnormal heart rhythms. And of course, don't forget to take a decent drug history, not just prescriptive drugs, but also the illicit drug usage as well. But the common ones that we prescribe that you need to be aware of are salbutamol. Patients who often don't or forget or ignore the advice to use their brown inhalers regularly and just think they can get away with just using lots of PRN usage of salbutamol. Eventually, these are drugs that will build up in the system, and that is a very powerful drive to stimulate the heart. Recent withdrawal of beta blockers. Patients who've been on beta blockers for a while, they're not really widely used now in hypertension, and a lot of us are just stopping beta blocker use in patients. But that can have a rebound effect in terms of stimulating the heart, and it's not uncommon to get palpitations. It's really important to tease out that in the history. And then we've got a long list of drugs that can prolong the QT interval, which of course many of these drugs are used in mental health, in particular the psychotics, and in particular the atypical antipsychotics. And Peter, if you don't mind, this is such an important issue because it's potentially a lethal issue if we don't take this seriously. There are certain drugs that, by delaying opening of potassium channels, actually delay the relaxation of the heart, the repolarization of the heart. That's everything after that QRS complex. You get this delay. And if that delay is more than 500 milliseconds, the patient is in a danger zone, because it could mean their next heartbeat, their next QRS complex could actually go straight on top of a T wave. And if that happens, these patients are at really high risk of a almost lethal arrhythmia known as torsade de pointes. So I would always take a good drug history and be very wary of drugs that can significantly prolong the QT interval. So haloperidol, chlorpromazine, quetiapine, these are the high-risk drugs that can do this. And I certainly, once I see QTC intervals approaching 500, I would like to think that I would have a low threshold for considering switching to drugs at lower risk, like, for instance, olanzapine and risperidone, much lower risk than quetiapine in terms of the QTC. Similarly, citalopram and escitalopram, not very widely used, quite high risk, whereas fluoxetine and sertraline are low risk. So just be wary of that drug history. I'm not sure if you've got, is it routine practice, Peter, from your perspective, to keep an eye on that QTC in your patients on these drugs?
Yes, absolutely. I guess the problem is that almost all antipsychotics and antidepressants will flag up as a risk, and we have these oversensitive systems, don't we, that will tell us to watch out. So it's something where you almost become a little bit blasé about it. But you're right, and I think maybe worth mentioning the risk factors for this. So underlying heart disease, age over 65, being female, more than one QT prolonging agent, electrolyte abnormalities such as hypokalemia, hypomagnesemia, and bradycardia are all risk factors, aren't they?
Really good point. You've got to check the electrolytes. The electrolytes themselves, particularly hypokalemia and hypocalcemia, can strongly influence that QT interval. I just think this is a variable response that patients have. Some patients, their QTC doesn't go up by very much, but we know drugs like quetiapine. Quetiapine for me is one that has caused an issue in this regard. On average, most patients' QTC might only go up by about 10, 12 milliseconds, but in about 15% of patients, it can go up by as much as 60 milliseconds. And if your baseline QTC is, say, 440, 450, 60 milliseconds is a a tremendous amount for it to go up. So I think we're almost duty bound for the psychotic medications to do a baseline ECG. I think we're taking too much of a gamble if we don't do that. And of course, I guess it's the remit of the person who's sort of initiated these drugs. But in my experience, often psychiatrists are a little bit loose on this. I don't know what your experience is on that.
Yes, I'm afraid I feel they often pass it to GPs, don't they? But yeah, I mean, it's difficult holding in your mind the different drugs because they're not ones we use a huge amount of. But I think you're right. So the higher risk, quetiapine, definitely of the atypical antipsychotics. Haloperidol, probably the only, and chlorpromazine, the more old-fashioned ones we don't use very much. So quetiapine, remember, big red flags, and citalopram, and as you say, escitalopram. And also maybe worth mentioning amitriptyline, because that's used a lot, isn't it, for chronic pain and things like that. And venlafaxine and mirtazapine, other high-risk
Yeah, absolutely.
drugs.
Venlafaxine and mirtazapine. So I would, again, you've got alternatives that can be used in patients with a highish baseline QTC. I mean, duloxetine, not licensed, got a similar license to venlafaxine in terms of its indication, but it pretty much blocks the same receptors. Much lower risk than venlafaxine, and same with. I'm not a great fan of mirtazapine myself, but some people are. But switching that to trazodone, for instance, would offer a lower risk. So I think that's important. By the way, you don't even have to be an expert at interpreting the ECG. The beauty of ECG in this regard is the machine does it for you, because if there's one very good thing about the ECG interpretation software, it's incredibly good at working out intervals. The subjective diagnosis is very variable, and I think I've sort of pointed this out numerous talks. But the numbers, so what you want to look at is the QTC interval, not the QT interval, because the QT interval varies depending on your heart rate. But the QTC is reference to the patient's heart rate at the time. And the ECG machine actually works this out very, very accurately. So you could actually get away without even looking at the trace and just looking at the numbers. So I think we probably better move on now to how do we take that history. And I guess we've got to start with the basics. Palpitations can mean different things to different people. So it's always worth asking patients, what do you mean by palpitation? And of course, for most patients, it's going to be an abnormal perception, usually unpleasant perception of the heartbeat. And remember, it's a symptom, and the majority are not due to an arrhythmia. And most patients, I think, Peter, would refer a palpitation to when their heart seems to be beating quickly, but that doesn't necessarily have to be the case. Theoretically, you could get slow palpitations, irregular palpitations. Some patients will describe a pounding sensation as a palpitation, missed beats or extra beats. So really important to clarify what that means. And then for me, I go straight onto the rate. I don't mess around anymore. I say, well, you've told me you're getting this awareness of your heartbeat. Can you tap it out for me? And it's pretty straightforward. You'll be able to tell whether it's regular or irregular. Clearly, if it's irregular, especially irregular, you're going to think more the atrial fibrillation route. But the rate is so important. If they're tapping it out and it's clearly almost too fast for them to tap out, going well above 150 beats per minute, that is almost always indicative of a tachyarrhythmia. So something like an SVT, for instance, or an atrial arrhythmia. If it's fast, but they can tap it out reasonably comfortably, so maybe 120, 130 beats per minute, then that is far more likely to be reflective of anxiety or a catecholamine-induced fast heart rate. And then the next question that I find very helpful, and this can all be done very quickly, ask how long it lasts. How long does each episode last? Because if someone tells you, I remember taking these really long histories of palpitations and I thought, God, this sounds really serious. And then the patient would say, oh, it only lasts a couple of seconds or 1 second. Anything that lasts less than a few seconds, it's highly unlikely to represent an underlying arrhythmia, okay, a tachyarrhythmia. You're really looking at ectopics. And ectopics, in my mind, patients will either say they're experiencing missed beats. So when a patient says they're experiencing a missed beat, it's probably because they're getting an ectopic. They don't actually feel the ectopic, but there's always a pause after an ectopic. And what they're experiencing is that pause. Some patients will describe it as a fluttering. For 2 or 3 seconds, I get this fluttering of my heart. And then other patients will actually feel the ectopic beat and say, I genuinely feel like I'm getting these extra thumps. So any history like that, yes, it might be very worrying for the patient, but for me, it's reasonably reassuring that we're probably dealing with ectopics. So how long each episode of palpitation lasts can be extremely informative. And then the other, it's always worth asking about the frequency, because if you are going to end up referring this patient for monitoring, ambulatory ECG monitoring, it's important for the cardiologist to know the frequency to work out what's the likely duration of monitoring that's going to pick this up. And our rule of thumb is whatever the frequency is, multiply it by 2 in terms of duration of monitoring. So if someone's getting palpitations every day, you would probably do a 48-hour Holter, or every other day, 4-day Holter, obviously factoring in available resources. I'm going to move on to alarm symptoms a bit later on, Peter, but I think, again, let's assess contributing factors. So, Peter, I'm not sure if you can give some input here in terms of how do we explore, and I think it is well worth exploring sort of the psychological issues at that first consultation, because often patients aren't very forthcoming about this, but I think it's well worth sort of exploring that as part of your initial, any sort of recent life stresses or bereavements. Really, I don't know if you agree with me, but I try and address them right at the outset.
Absolutely. And I think you've got to be really careful in the way you do that, because a lot of patients will feel gaslighted by suggestions that it's all in the mind. So you've got to be very sensitive when you're taking this sort of history. But it's absolutely valid. And certainly I've seen people who have had palpitations because of anxiety. You're mentioning drugs earlier, by the way. Another one I'd throw into the mix is caffeine. I don't know if you see this, but I see a lot of lorry drivers who have Red Bull and similar high energy drinks to keep them awake, and that can have huge issues.
Yeah, no, I was definitely going to move on to that. So, I mean, in terms of lifestyle, not just caffeine, alcohol lowers the threshold for ectopy, and don't forget about the illicit drugs like ecstasy and amphetamines, and cocaine, obviously common cause of palpitations. We've talked about those prescription drugs, the beta agonists, the theophylline's not very widely used now, and of course the QT prolonging drugs. So actually it sounds like we've gone through a lot, but actually it doesn't take that long in most patients to tease out the important aspects. But what I move on to next is a family history, because there are certain conditions in cardiology that are just simply designed to kill you. I'm talking about the channelopathies or cardiomyopathies, hypertrophic cardiomyopathy in particular. Thankfully, from a history perspective, not for the patient, these conditions are autosomal dominant. So you really don't have to delve very deep in the family history. They're usually apparent in first-degree relatives, brothers, sisters, parents, grandparents. Anyone, particularly any unexplained death in someone under 40. So, I always remember this patient of mine who said, my brother was a fantastic swimmer and he had an unexplained drowning in a sort of still lake. I mean, you've got to wonder what's going on there. And whether and we know the dive reflex can precipitate certain malignant arrhythmias, and also that patient who's had an epileptic seizure that caused polished him off. Basically, we know that about a third of epilepsy is often misdiagnosed and can be reflex seizures secondary to an arrhythmia. So I think anyone who's had a family history, first degree, sudden death under the age of 40, take that seriously, and it just makes you a little bit aware, make sure you're not missing anything. And then that really leads me on to the red flags. You can have the most benign sounding history of a palpitation, but there are certain red flags that should automatically raise the alarm bells and create an urgent need for investigation. And that's anyone who's describing palpitations on a background of significant heart failure with an ejection fraction of less than 35%, previous heart attack, anyone with scarring of their heart, basically. By the way, these red flags are all there to pick up that patient who might be having a ventricular arrhythmia, ventricular tachycardia. And the reason we're so concerned about ventricular tachycardia, thankfully a very small minority of patients who get palpitations, is because VT is one step away from degenerating into VF. And then once you're in VF, without a defibrillator, it usually ends up being a post-mortem diagnosis. Okay, so these red flags are just there to identify that patient who's having palpitations that could be due to VT. So heart failure, previous heart attack, and I would also add in congenital heart disease or a significant valve problem, particular significant moderate to severe aortic stenosis. And then the next red flag symptom or sign or from the history is anyone who gets palpitations with associated syncope or pre-syncope. Yes, palpitations can cause anxiety and they might say, I'm feeling a little bit dizzy with these, but they shouldn't get significantly lightheaded to the point where they think they're going to pass out. So anyone with pre-syncope or syncope, you've got to be thinking, could this be VT? Because VT will definitely cause a reduction in your cardiac output. And then we've talked about family history. Anyone with a family history of sudden cardiac death or sudden death below the age of 40. And then the big one is patients who reliably tell you their palpitations only occur during exertion. If someone's telling you, I only get them when I exert myself, again, that is a sign that this is potentially VT. Because VT usually is precipitated when the heart is under strain. And so be very wary of exertional palpitations for that reason. So I would suggest anyone with any of those red flag features probably now needs to see a cardiologist. But there's a lot you can do prior to that, and most patients don't have those red flag features. So it's well worth doing a basic examination. You don't actually have to be very onerous in this regard. To be honest, most patients with palpitations are going to have a normal examination, but it is well worth feeling the pulse. I mean, you can diagnose atrial fibrillation, not diagnose, but you can certainly screen for atrial fibrillation straight from a pulse check, irregular, and then you go straight onto the ECG. Obviously, look for signs of heart failure. Look for or listen for aortic stenosis, that systolic murmur in the right sternal edge, upper sternal edge. And then in terms of blood tests, it's very straightforward. Full blood count, thyroid function, and electrolytes. Rule out the high cardiac output state, rule out electrolyte abnormalities. And then everyone needs a 12-lead ECG. Okay, that's a topic in itself. I'm not going to go through all the things that you're going to identify, but there are certain things on the ECG, like the QTC interval, features of cardiomyopathy, ischemic features that you need to look out for. And I think anyone with an abnormal ECG with palpitations, again, merits a cardiology referral. But if you've got a normal ECG, no alarm symptoms, a history that's very suggestive of ectopics, I think we can really draw a line under this diagnostic workup. And then your job is to now reassure these patients. Absolutely. And be definitive. Don't sit on the fence. Just say, look, all the tests are pointing towards a very benign cause for your palpitations. And I think if you're definitive about this, it's amazing how many patients palpitations then absolutely disappear, because assuming it's a lot of it, you've broken that vicious cycle of the anxiety propagating the underlying issue.
That's a really helpful summary, Yassir. And very often I'll reassure patients, and actually all I've done is transferred their anxiety into my head. But hopefully with that checklist, I'll be able to do it a bit more definitively.
I think that's a really good point. But occasionally you are going to get a patient who's just pushing you for a little bit more. Obviously, there's a danger. The more you investigate, the more you're going to fuel the anxiety, because the patient's probably thinking, oh, well, maybe there is something that's worrying the doctor. But if there's one extra investigation that you're going to do in that scenario, out of all the investigations, it's not actually a Holter in that low risk scenario. In that scenario, it would be an echocardiogram. If you get an echocardiogram, get yourself a direct access echo, and it's completely structurally normal with a completely normal ECG, you are virtually home and dry in terms of excluding a sinister etiology for those palpitations. So if you are being pushed, get that echocardiogram. But as I said, anyone with red flag features or symptoms that are suggestive of a tachyarrhythmia, refer to cardiology.
So,
Peter,
as we're coming to sort of wrap up, we're hoping, I think, that these podcasts will give practical advice to busy GPs, i.e. all GPs. And what I've taken from what you've said is tap out the rhythm, which is something I've never thought of doing, but will now do that as part of my routine workout. In younger people, take a family history of sudden unexplained death or death through cardiac causes. And then the red flags: heart failure, previous heart attack, CHD, valve problems, associated syncope, exertional palpitations, or an abnormal ECG. Does that pretty much cover it, Yassir?
Yeah, it does cover it. Actually, if you don't mind, there's just a couple more tips actually on the history. Always ask patients, if you can, what brings on the palpitation, or how does it turn on and off? If it turns on and off like a light bulb, so 1 minute they're absolutely fine and then literally their heart's going like the clappers, that is very, very suggestive of a tachyarrhythmia. And if it stops suddenly, again, that's a tachyarrhythmia. If they say it comes on reasonably quickly, but over 1 or 2 or 3 minutes, then that's really a catecholamine-induced, probably anxiety that's driving that. So not a light bulb, but over 2 or 3 minutes, that's very suggestive of anxiety. And the other thing is, a lot of patients have worked out how to stop their palpitations. And if they're getting SVT, which is a very common arrhythmia in young patients, a lot of them have figured out, if I cough a lot or hold my breath and push, I can stop it. Because what they're doing, of course, is a Valsalva maneuver that's blocking their AV node and obliterating that reentrant circuit that's causing their SVT. I mean, if you get a history like that, you know it's an SVT. And then another really clever one is some patients get palpitations every time they eat or drink something very cold. Because what happens is your esophagus is right next to your left atrium. And as the left atrium cools, it can trigger paroxysmal atrial fibrillation. This is quite a well-known phenomenon. So it's well worth asking any triggers and the pattern of onset and offset. Again, honestly, from a history, I've usually got a very good idea as to what the underlying etiology is. Is it an arrhythmia? Is it anxiety? Is it ectopics? Just by asking those extra questions. And it's really well worth putting that down on the referral form as well to give the cardiologist an idea of what you're thinking.
That's fascinating. And again, I've certainly experienced what you've just described on a hot summer's day abroad when we're allowed to, having an ice smoothie and thinking, oh my God, I'm having a heart attack. And then repeating it 5 minutes later and getting the same thing just to see if it really was. So now you've explained that. Thank you.
And maybe, Peter, just before we end, maybe we should give a bit of a nod to the difficult situation we're all faced with at the moment. The pandemic. I think one of the great issues with the pandemic has been the underdiagnosis of all conditions, but in particular, from my perspective, cardiovascular conditions. I've seen atrial fibrillation diagnoses have plummeted in the last year because, of course, we're not doing as much opportunistic stuff. So one of the silver linings of the pandemic has been this hugely increased appetite for adoption of technology, not just in terms of not just technology, but innovation in general, different ways of working. And I would strongly encourage, for patients who are complaining of palpitations, to see if we can utilize some of these wonderful kits, these portable ECG devices that pair with your smartphone. So patients can actually, as soon as they get their palpitation, they can actually record it, email it to the surgery, and you can actually capture that very easily and document and record it in the notes. I mean, I've certainly made a number of diagnoses now of ectopics, couple of VTs, and certainly a lot of atrial fibrillation without patients having to leave their living room. I mean, it's wonderful technology that I think we should be embracing now in this post-COVID era.
Absolutely. But it's good to hear that taking a history is still important and can still tell us the story most of the time.
Crucially.
Fantastic. Yes, so thank you very much. That's been an absolutely fascinating look through what I always find is a difficult subject. I think I feel confused at a higher level now. So hopefully a little bit more confident when the wave of post-COVID anxiety present with palpitations. And thank you to you all for listening. We hope you found this podcast helpful. Please make sure to register both for the other podcasts in the series and for our interactive webcasts brought to you as part of Chronic Conditions Month 2021. You can sign up if you're interested at chronicconditions.co.uk. Thank you again, Yassir.
Thank you very much.